from Ball State Community College's Respiratory Care Program. I'm here today to talk about a clinical simulation of a woman with COPD and weaning her from a mechanical ventilator. Mrs. Tubbs, a 50-kilogram ideal body weight emphysematic patient who has been living with a diagnosis of COPD for almost 35 years, is currently being mechanically ventilated. Dr. Chrisman has asked me to be very cautious with the weaning and liberation from mechanical ventilation due to previous reintubations post-extubation. She has been mechanically ventilated 3 times prior to this hospital stay for COPD exacerbation. Each time she has had difficulty maintaining spontaneous ventilation post-extubation. After checking the chart and seeing her history, I decided to check her normal baseline ABG. Her baseline ABG values on a 2-liter nasal cannula are as follows: pH 7.38, PaCO2 60, bicarb 30, and PaO2 60. These values reflect her diagnosis of COPD and demonstrate that she is a chronic CO2 retainer. I observed current chest x-ray findings and note that she has flattened diaphragm. A flattened diaphragm results in decreased respiratory muscle strength. The loss in respiratory muscle strength must be taken into consideration when weaning because it can result in the loss of the ability to efficiently take spontaneous breaths. We need to make sure that her secretions are optimally cleared because of the inability to effectively clear secretions that occurs due to decreased muscle strength, ineffective cough, and decreased mucociliary transport that often are an outcome of emphysematic patients. When weaning a COPD patient, it is invaluable to wean the patient to their appropriate baseline ABG. If weaned to a normal lung patient's ABG values, a COPD patient will ultimately fail weaning parameters. Upon entering Mrs. Tubbs' room, I observed her current ventilator settings. They are as follows. She is in SIMB, frequency of 10, tidal volume of 450, and a FiO2 of 35%, pressure support of 5, and a PEEP of 5. Since it's a test lung, there obviously isn't any spontaneous, but in this clinical simulation, she has the set rate of 10, but her total rate is 13, and her spontaneous tidal volume is 250 milliliters. Her vital signs are stable and normal for her age and cardiopulmonary disease. Her SpO2 is 91%. Dr. Chrisman asked that she be weaned to minimal mechanical values of an SIMV rate of 4 due to her long-standing COPD. I decided to turn down her rate in increments of 2 and allow her 2 hours to adjust to having to take more spontaneous breaths before I make another rate change. After the rate change, I titrate down her oxygen to 33%. I decide to wean the FiO2 in small increments due to her sensitivity to oxygen changes because of her emphysematic COPD condition. I will maintain her pressure support at 5 in order for her to be able to overcome the resistance of the endotracheal tube and make effective spontaneous breathing. I will keep PEEP at 5 in order to keep her alveoli stent open due to her predisposition of premature airway collapse. 30 minutes after each rate change, I draw an ABG from her arterial line to better assess her ventilation and oxygenation. I will correlate the ABG values with her SpO2 and her EtCO2 value in order to assure that her non-invasive parameters are accurate. Several hours later, she now has the following ventilator settings: mode SIMV, rate of 4, total rate 12, mechanical tidal volume 450, spontaneous tidal volume 400, pressure support of 5, PEEP of 5, and an FiO2 of 28%. Throughout the weaning process, I have closely monitored her vital signs, ABG values, and performed meticulous patient assessment for any sign of respiratory distress. On her previous ventilator settings, her ABG values were as follows: pH 7.38, PaCO2 60, bicarb 30, and PaO2 of 60. Since her ABG and patient assessment was stable, I decided to contact Dr. Chrisman with all of her settings and values, and she orders a spontaneous breathing trial with a pressure support of 5, PEEP of 5, and to maintain her current FiO2 setting of 28%. Since there isn't a test lung that can breathe spontaneously, I'm just going to keep these settings. but just know that you would obviously put a patient on a spontaneous breathing trial to see how they would breathe on their own without any backup breathing. 30 minutes after initiating the spontaneous breathing trial, I obtained an ABG and weaning parameters. Her ABG values are as follows: pH 7.36, PaCO2 62, bicarb of 30, and PaO2 of 58. Her spontaneous tidal volume is 375 mils. Respiratory rate is 14. Tobin index is 35. You get the Tobin index by dividing the respiratory rate by the tidal volume. Vital capacity is 750 mils. And a MIP of negative 27. SpO2 92% and an EtCO2 of 48. All of these parameters are in range for a person with COPD, and it is determined that Mr. Stubbs should be extubated to a nasal cannula at 2 liters per minute. However, almost immediately, she became tachypnic with an SpO2 of 86%. She appears to be hyperventilating. I would expect her PaCO2 to be lower than normal and her PaO2 to be lower than normal while she was hyperventilating. As she becomes fatigued, she will begin to fail, and her PaCO2 will rise above her normal value, and her PaO2 will probably continue to decrease. After sharing the findings with Dr. Chrisman, we decide she needs immediate BiPAP therapy to assist her spontaneous breathing efforts. I decide to use a full face mask because she is an obligate mouth breather and she is in distress. I would fit her using the plastic guide on the packaging, starting with the small because she is a small woman and going up. This is how you basically put the nose and chin through there. The small would be a little bit small for me, but the medium would be just right. It is on the bridge of the nose and down tight on the chin. I fit her and she wears a medium mask comfortably. I'm going to turn on the BiPAP. We've already preset the spontaneous parameters that we want. So I'm going to go to monitoring, parameters, IPAP of 10, EPAP of 5, rate of 12, and I've got the FiO2 on 21% here in the lab just because we don't have real oxygen flowing through the flow meters, and I'm trying to prevent it from alarming every 5 seconds. So basically, once you have somebody on the BiPAP, you want to make sure that your IPAP and EPAP are satisfactory by you're going to assess the patient. You want her to reach a good tidal volume, and she is pulling a tidal volume of 400 mils. I'm going to go ahead and turn that off so it stops alarming. I monitor the effectiveness of BiPAP therapy by using patient assessment, especially her level of consciousness, vital signs, and ABG values. You want her ABG values to be normal according to her baseline. If she begins to have a decline in responsiveness or level of consciousness, her vital signs become unstable, we will immediately call a rapid response and possibly prepare for a reintubation. Thank you.